them at any time you so choose. And so we can get started. We'll probably have a couple people join us as we go. I'm Daniel. I haven't been here for 2 weeks. I've been on vacation, as I already said before. And so it's great to be back. Glad to see the ship is still floating, as it were. So I think, and this is the last call we're gonna have for the year. We're gonna take off the next 2 weeks and then new plans in January of next year for new people who are joining us here. There's some new people on the call and some existing folks who are here. So what I thought we would do, and thanks everybody who showed up, has been showing up, is just do a couple of things on the agenda. I want to really hear a lot from our guests today. It's so much in the alignment of where we're at and where we're going with interoperability and consent. So we'll minimize. Generally, we just spend a few minutes kind of doing a couple of open, sort of updates on things that are happening. I want to talk a little bit more about the California thing that I'm actually presenting at tomorrow in preparation, not really preparation, but in advance of our Friday call on consent. So just a minute on that, and then we'll, I don't know if we have any updates. Work group updates have been, Brian, is there anything we're going to talk about at all?
Yeah, I should probably just announce that that on Friday, and I'm just double checking, yes, Friday at 1 p.m. Eastern time, we're having a Project Unify ontology full group meeting. I'd yield to Eric to present on this, but I think Eric is on vacation today.
That's the rumor.
And about the only other thing that I have to announce is that we had our second Information Exchange for Human Services, IXFIS, meeting at noon this afternoon. We had, I think it maxed out at 33 participants, though it may have gone up by 1 or 2 or 3 more since I was busy running the meeting and not busy watching, the numbers run up and run down for participants. We had some great contributions, not counting the Russian bots. Thank you, Jim. Yes, we desperately have a problem with that in IXFIS. I'm happy that they know about us. We made some great progress in refining the proposed charter for this group. And next month on January 19th at noon, we'll have the first formal meeting of the Direct Trust Information Exchange for Human Services consensus body. So if this is something that at all interests you, providing a voice for the human services, social services community and helping them define their requirements, identify, evaluate existing standards, define new standards where they need to, drop me a line and I'll make sure that you get an invite to the next meeting.
Great, thanks, Brian. And you can chat that out there. Our tradition is just to welcome new people and torture you with needing you to identify yourself, say hello and where you're at, so we can know who you guys are. So I would ask Angie, and welcome as one of our presenters today, to say just where you're from and what you're doing.
Yeah, thank you so much for having us today. And I apologize again that I'm calling in addition to being on the phone, but I'm Angie Brenner, and I am the Deputy Director over Administration in our Missouri Department of Mental Health Division of Developmental Disabilities. I've been in the Medicaid arena for, golly, 22 years? I think it's 22 years now, working over at our Medicaid agency for 13 of those years, and then I've been here at our Department of Mental Health, specifically in our developmental disabilities division for the last 6 or 7 years. So been here for a little while. We have started our journey with this whole value-based payment system and methodology that we're looking at, and interoperability for the last 3 years. And we'll talk a little bit more about that today. But yeah, that's a little bit about me. So if you don't mind, I'll pass it over to some of my team members that we brought today too.
Great, great.
So Dwayne, you're on the line too?
Good afternoon. My name is Dwayne Shoemate, and I'm also with Missouri Department of Mental Health, Division of Developmental Disabilities. I'm the State Coordinator of Employment and Community Engagement, and have worked here at our division for about 8 years. Previously, I worked 21 years within the vocational rehabilitation field and executive officer, national board member for the Association of People Supporting Employment First. And I will turn it over to Sheetal Shah.
Thanks, Dwayne. And hi, everyone. Sheetal Shah. I'm an independent consultant with EMI Advisors supporting the state of Missouri in the LEAP grant. And a little bit about my background. I'm based in New Jersey. I was formerly working at ONC and the Center for Medicare and Medicaid Innovation, and have worked in New York City at various stage digital health startups supporting value-based care implementation prior to joining, working with the state and on other SDOH related projects with the EMI. And then Brenda, I'll give it to you.
Hi, everyone. I'm Brenda Kinabit. I'm a policy analyst with the Office of the National Coordinator for Health IT. With ONC, I support the LT PAC space, and that's how I was introduced to this lovely LEAP Missouri team. So I'm hoping we get to excite you guys a little bit with some of the work that they have to share. This has definitely been quite a journey for me. Prior to my role at ONC, I worked in infection prevention and control at the largely supporting acute care hospitals, but also long-term care facilities, behavioral health facilities. So being able to see just, all the work that goes into making health IT interoperable for people in the front lines has been really interesting for me to learn on this past year. So I'm very excited to be here.
Thank you very much. Aaron, since I don't think you're part of the Missouri team, I'll call on you.
Hello, sir. Happy to be here. I'm looking forward to catching up with the whole crew. Very excited to contribute when I can.
Happy to be in any meeting that Aaron's in.
There's usually scotch involved, right?
That's usually Scott's involved. That's right. Aaron and I go way back. We've had previous business relationships in previous life with New Wave. And New Wave has done some exciting stuff around Medicaid and fire, stuff that Aaron has contributed specifically. So thrilled to see him on board.
Hey, guys. Thank you for that warm welcome.
We usually believe what Jim says.
I'm Aaron's colleague at New Wave. I don't know if everybody knows New Wave, but we're a contractor technology engineering firm that provides services to a lot of programs at CMS. We're also the primary architect and technology contractor for the Center for Innovation. We also, Aaron helped start the company Onyx Technology, our sister company, which has built the Sapphire platform, a sort of industry-leading interoperability platform. And we're really excited to try and build the necessary technology for social determinants of health to be widely used and effectively used across the healthcare industry.
They paired Michael and I up because we look so much alike.
Brothers from another planet.
That's right.
Yeah.
For those who have seen that wonderful movie. So just have a couple of things I wanted to share, and then any other updates from folks on the call here, and then we'll just jump into the presentation and mix it up and kind of hear what you have to say. We're really excited to hear more examples of folks doing what you're doing, which is great. As I think I mentioned, well, everyone on this call probably knows, most people know, on Friday, we're going to be holding an hour call on the consent scan that we finished. I don't know if our Missouri friends have seen it, but we can put a link to it in the chat there. It's a collaborative effort over the last 6 months or so, longer than it actually. A lot of people on the call here and a bunch of others really looking at consent across the country and some promising practices and legal and technological and governance issues. So we have a sort of an intro call presentation on Friday at noon. It'll be 7 presenters, 60 fun-filled minutes of everything you want to know about consent. And it's just a start of actually disseminating that. We've been out there, we just put it out about a month ago, 3 weeks ago. And now we're just trying to get it out there and get the conversation going because of its relevance to all the work that's happening around data sharing and interoperability across the country. And there's a lot of stuff percolating especially around the LEAP work. We looked a lot at the San Diego LEAP work and um, various other promising practices around the country. So so that's Friday. And then, as I said, tomorrow I have the great fortune of being able to presenting in California at the coalition that Jim just mentioned earlier about the consent work as well. Our history goes pretty far back into California, and it's interesting to see, particularly with what's happening in New York and the Rio in New York, as potentially one of the places where we may be doing a proof of concept around the consent utility. A lot of that sort of resonates and started in California. So there's a lot of interest in going back and forth between those two areas. And so they're trying to connect all their HIEs across the state, as is New York trying to connect all theirs, right, with the Shiny project. So it's kind of a parallel worlds that are crashing together, that we kind of have a view into both sides of it, which would be great. And ultimately, if we can do stuff on consent and on the East Coast and the West Coast and the Midwest, a couple of different places around, the idea is to sort of find places that really need to gain and acquire and enable consent, then maybe there's an opportunity to create a utility. So that's the mission we're on as we go forward, as it were. So looking forward to any comments, and then we can jump in.
So Dan, this is Aaron. I wanted to real quick, because you gave me an early peek at that report.
Yeah.
It's extraordinary. I think it's really worth everyone's time as far as, it's a great consensus or aggregation of what's going on. Very, very helpful for a lot of folks, I'm sure.
Thanks, Aaron. It's great. It's great to hear that. It's we always like to give credence to Adam for pulling together as the editor of 25 different authors a document that is it is a good.
I think that's hard enough. Oh my God! And she's still up and running. That's amazing.
Isn't it? It's a testament to his patience and editorial.
It's quite a lift. 25 people on consent, nonetheless. One of the more trivial problems we're trying to solve.
Right? Exactly. Why not pick a hard one?
Not to mention that I didn't understand about half the stuff I was writing and editing.
Well, that's great to hear that, and that's what our mission is to really, and as you noted in there, and what we discovered was really we didn't find anybody who actually done something like this in about 8 years. MITRE did a report for ONC on consent, but it was very, 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 very healthcare focused, and then there really hasn't been much published since Bougie and Company has done some work around advanced directives, and e-consent has started to evolve recently. So it's really trying to say, okay, let's take a moment in time. Where are we? What are the pieces can we add to it, as opposed to having to recreate the damn wheel every time? It's such a heavy lift. You really need 25 or 30 people to do something like this, because the expertise is so distributed. Without that, it's really impossible to get a view. And I think we contributed on the social sector side and education and justice side, and bringing those pieces to the table and say, look, this has to be connected too, right? Consent and education is a big part of it. And that's a big, tough conversation. So I'm glad we're on the road to it. But it'll be a long haul. So with that, Bill, do you want to say a few words? I know that you were gracious enough to make an introduction for us to find folks in Missouri. And
sure. Sure, absolutely. Just to set the stage, and I don't want to steal any thunder from this great Missouri team here, but just a little bit of background. The ONC had announced an opportunity under their LEAP grants, and there were 3 areas in that opportunity. The third area was integrating healthcare and human services data to support improved outcomes. And that is the area that Missouri won the grant on and have been working on. So I'm not going to go into details of that because I know they will. But one of the things that I'm excited about too is not only how they've approached and what they're doing with this grant, but what they're going to do in the future. You know, I've seen many pilots that you have a pilot and then the pilot's over and that's it, and nothing happens after that. And so I think the plans and the way Missouri's going is really very exciting, and it's going to make this the future of what they do in that state. And before I hand it over, just one cheap plug for FEI. The support plan that they're using is on FEI's platform.
Cool.
So with that, I will hand it over to you, Angie.
Thank you so much, Bill. I really appreciate it. Cecil's going to share some screens for us here. We are really excited, and it was a little scary too in the beginning, kind of the direction that we were going, because it's just like peeling back layers of an onion, and it just grows and it grows and it grows, which is great. But as Bill said, that we are completely under a paper-based system right now, and we've contracted with FEI to move to that case management system. At the same time that the opportunity for the LEAP grant and some technical assistance happened for us. So we're kind of thinking like all of our stars are aligning. So we are excited about that. So again, thank you for having us today. We really appreciate it. We're really excited to kind of share our journey where we successfully connected the ELTSS data among service providers, case management agency, primary care physician, all through a health information exchange at that Connect-a-thon. So we already did introductions, but again, our speakers today, myself, Dwayne, Brenda, and Cecil. So I'm so thankful for them to be able to join us too. We will go on to the next slide. So we're going to talk a little bit about Missouri landscape and background, and I'm going to let Dwayne jump in here and kind of give you the background and set the stage for where we're going. So Dwayne, if you don't mind.
Sure. Thank you, Angie. So, you know, one of the things, anytime I think someone's presenting from a state perspective, I think it's always good to give everybody kind of just an environmental scan of, you know, who Missouri is and the individuals that we're supporting. So as we go to the next slide, just to start off, this is a kind of a demographic breakdown of the individuals that we support through the Missouri Division of Developmental Disabilities through our waiver programs. About 60% are male. As you can see, the overwhelming majority, 75%, are Caucasian. Our top 4 types of disabilities are intellectual, autism, other cognitive, and then mental health. And again, the individuals that are supported through our waiver and accessing part of these case management systems range in age from 1 until 92 years of age. As we go on to the next slide, again, we do contract with 500 plus providers in Missouri. We do have quite a few large contracted providers that are using some online case management systems. And then we do have, some of our large providers that are really still doing some work on paper. But really what we see a lot of is our very small providers, kind of our mom and pop providers that comprise the vast majority of those 500 plus providers. They may not even be using computers yet. They may still be doing handwritten paper pen notes. They may be parts of the state where we have very limited connectivity to the internet. And so, obviously a lot of that data exchange is occurring and continues to occur through phone, fax, email, and then the good old fashioned snail mail. But we are transitioning, throughout our state to an online case management system that will be part of the state system, and then each of our contracted case management entities would be working within it. And that case management system, as Bill noted, is on the FEI platform, which will be exciting because we will then begin to connect, a lot of individuals throughout the state of Missouri across our 114 counties. So moving on to the next slide. So that's just a little bit of the background of kind of the providers that we're working with and the individuals that we're supporting. Of a little bit of significance as we talk further is that we are an employment first state. One of the things that we're really wanting to do is ensure that the individuals that we're supporting are being affirmed in their opportunity to work in the community. As we go on to the next slide, one of the reasons that we have that as a focus is we do know the impact of employment on social determinants of health. A lot of research over the last 20, 30 years on how those who are employed have better overall physical health, better mental health. They have more social connections. They have a lower incidence rate of late stage diseases And obviously, those who are employed have fewer financial pressures. So I know we're a little pressed on time, so I don't want to go through this. I'll let you guys kind of look at that. But obviously, what we are wanting to do is exchange data to help inform us on employment and employment outcomes and how we can use those outcomes to develop future alternative payment methods that really recognizes those providers across the entire care landscape that are supporting the individuals we support and going to work. On this slide, the vast majority of our current dollars are expended in residential programs. Again, you can see that our day program and then personal assistance programs comprise kind of our second and third expenditure. And then you look at employment, and in the totality of our budget, it's a very, very, very small percent of our budget at 0.7 to 0.8%. But obviously, if we begin to leverage greater employment outcomes and people have those improved health outcomes, we would be elevating those expenditures around employment and hopefully reducing some of those other expenditures around residential day program. And so with that, just a little bit of context. So I'll turn it back over to Angie to talk more about what we've been doing and where we're going.
Thanks, Dwayne. In partnership with our Medicaid agency, Department of Social Services, Mental Health Net Division, and then our Department of Health and Senior Services, our focus really was about learning about VBP models, so value-based payment models, the data, stakeholder engagement, and then just development of a roadmap on how to get there. Of course, one of the first things that we learned is that we don't have enough data. Our systems aren't talking to each other to the level that we need for them to be talking to each other. When we started this collaboration process with the other agencies, our use case through that technical assistance was personal assistance service because it spanned all of our agencies with our shared waiver participants. However, as part of the national efforts to advance VBP, all of our Missouri agencies, we participated in that accelerator program. Again, that was a collaboration with CMS, Center for Medicaid and Medicare Services, and then Center for Medicare and Medicaid Innovation, and really looking to improve that health and health care for all of the Medicaid beneficiaries, as well as just trying to help us across the agency determine opportunities for reducing unnecessary costs within that Medicaid ecosystem. Missouri was one of the 10 states that participated in the cohort to advance our VBP efforts, and we did that from April 2018 through August of 2019. And then on the next slide, we have some key milestones. As I mentioned, we've been working on this for the past 3 years, really or longer, exploring and designing kind of that value-based payment model for individuals with developmental disabilities. And with this timeline graphic, we just want to highlight a couple of those key milestones and just recognize those accomplishments to date that we're building on that's helping us to continue our value-based payment journey. So as I mentioned, we started this process in August of 2018 with our IAP. And since then, we've journeyed developing use cases, revising our employment waiver reporting requirements in our waiver applications. We've contracted with FEI as our online case management vendor. And then through all these discussions, we're really trying to lay that foundation for the value-based care models in a fee-for-service environment through the use cases, through that mapping to data standards and submitting kind of that new language and waiver renewals. I think, and you all probably realize this as well, but you often see those value-based payment care models in managed care environments, and we are still truly fee-for-service environments. So Missouri was granted the LEAP award in September of 2020, and that will help us move towards that next step of testing that real-world use case. We did participate in the Connect-a-thon in this last September 2021. Before we did that, we launched our LEAP pilot work group, and we launched them in November of 2020. And so really that almost full year was what it took to kind of get us to the place where we could participate in that Connect-a-thon.
Angie, if I could ask you a question. So you were awarded participation in the IAP. I'm curious, how much in advance were you preparing for that? Or how much time was there to get ready to do that? Because I know in the case of ink, it took a long, long time to get folks ready to even submit something.
Right. So for the IAP that we started in 2018, we had actually been talking about it with the state. Gosh, I started here in 2014, and I think my first HCBS conference was the the fall of 2014, and that's where we started to hear CMS talking a little bit about the value-based payment. And
Yeah.
I came from a managed care world when I worked at the Medicaid agency, and so of course I was like, yes, we're doing this. We're gonna get this done. And I come back and I'm like, oh, this is a whole different environment than managed care. So we started talking about it as early as 2014, and it wasn't until, every time I went to that annual conference, I hear a little bit more and a little bit more. So I would say that we had really been trying to kind of think about it, mull it over in our minds, try to flush things out for at least the 3 or 4 years before the IEP was actually offered to us. So I think by us just having those conversations here at the state level, that made it easier for us to be able to lay out the request to be able to participate.
Mhm. And I assume that sort of greased the skids for the LIPA grant, right? So
Yes,
you kind of had
yes,
that track
it did.
record, and yeah.
It did. It
Right.
did. It was through that technical assistance that we were connected then with ONC, and really kind of started on that parallel track of understanding the data complexities even more so. So we appreciated that connection that CMS made for us with ONC.
That's great. That's great.
Mm-hmm. Yeah, and then here, this is a common slide that I'm sorry, next slide on the developing roadmap. She's looking at mine. On this slide here, this is a common one that states see. This area circled in red here, that's really where we see that we're at, is trying to develop that BBP strategy measurement system and collect and analyze that baseline data. I remember going to the conferences and listening to CMS talking, and they often said, don't expect for this to happen unless, it's going to take at least 5 years. I thought that was crazy until I got into it. I'm like, oh my goodness. And you can see our timeline. It is taking a while, but we're moving in the right direction. So that is exciting.
What, if I could jump in, one question on the data. Is
Mhm.
most of the data that you're collecting or looking to collect structured or unstructured,
So
or a combination?
we're actually looking on being able to collect that data. So right now, like I said, it's been kind of that paper-based system. Everything is just Medicaid claims data. So
Actually, what I meant is there a lot of narrative data versus sort of drop down, sort of fill in the blank data for
Yeah.
behavioral and mental health? How does that play out?
Yep, that's a really good question. So again, kind of on that paper system that we have, everything is narrative, because our person-centered plans, it is based off of that justified need. So you talk with your planning team, what are the needs that you have? What resources do you already have? What resources do you need? So it is very much so a narrative. I think as we're building, and Bill and Dwayne may be able to answer this a little bit better, but as we're building connection, and we're talking about adding like case notes, things like that, there will still need to be those narrative components, because that's how our person-centered plan is developed. It's very different than when, like over at Department of Health and Senior Services, which they have home and community-based waivers. Theirs is a little bit more, I don't know, I want to say clinical in nature, but it's not necessarily as clinical as state plan services. They have more of that task check mark, drop down menus, check mark the boxes. We are trying to streamline that as much as possible as we build our system, our online case management system. But there will still be narrative and reports added to the system.
What I will just add is, from my perspective and some of the things that we're doing around employment, the data we're looking to capture, Dan, that's been one of the big headaches, is trying to move unstructured data over to structured data and get consensus amongst all the stakeholders on how to structure that data. That's where, I think going through this journey and really looking at the ELTSS data elements has helped us conceptualize how to better accomplish that, and then to be able to work with our stakeholders on the importance of us getting to structured data and data report sets.
And I think it's hard whenever you've done paper-based systems your whole life. I think sometimes it's hard to visualize that change to what is possible in that, that structured system. So it's been nice that FEI has put together whenever they'll try to lay it out for us and do some presentations saying, okay, here's what it can look like. And we still have more of those coming up. But it is hard, I think, for our team to visualize that difference and the capabilities that you have when you move to that online system.
Great.
Okay, so with that, we're going to start digging into the LEAP project itself. And so I'm going to turn it over to Brenda with ONC to kind of talk a little bit more about LEAP.
Thanks, Angie. Yeah, so a bit more about LEAP. The Leading Edge Acceleration Projects, or LEAP, were initiated in 2018 with the overarching goal to address well-documented and fast-emerging challenges inhibiting the development, use, and/or advancement of well-designed, interoperable health IT scalable across the healthcare industry. So LEAP projects are funded through ONC. The program and its portfolio of projects are expected to inform the development, implementation, and refinement of standards, methods, and techniques meant to further a new generation of health IT and supportive care and research. Next slide, please. So in 2020, the year ONC awarded the Missouri Department of Mental Health an award, there were 3 focus areas, and we'll talk a bit about that shortly. And I know Bill mentioned it as well, but just to give you all some background on where this whole grant came about, in recent years leading up to the LEAP grant, Health and Human Services had emphasized the need for improved coordination and appropriate integration across healthcare and human services providers to improve the delivery of services and supports, health outcomes, and to support value-based payment goals. And the lack of effective coordination across healthcare and human services providers, we know really comes at great cost to the patients, caregivers, provider, the whole health system as a whole. But the good news is that there are tools that we could potentially use to improve some of these issues that we're seeing. So in fiscal year 2020, the LEAP grant actually put out a special emphasis notice, and it asked for applications whose specific aims address one of 3 areas. And the LEAP Missouri project focused on special emphasis notice area 3, which was integrating healthcare and human services data to support improved outcomes. So the LEAP Missouri project is under a 2-year grant, and you'll get to hear a little more about that midpoint demonstration that occurred at the September Connect-a-thon. So really great work and efforts have gone into this project to get it to where it's at. And I'm definitely excited for you guys to hear more about that. Next slide, please. So if folks aren't as familiar with the ELTSS data set, it's an output of the person-centered planning process. And at ONC, we do envision that this data can be incorporated into various programs across Medicaid and HCBS providers, health and wellness, transport, home and mobile health. There really are a lot of potential uses for this data once it's standardized. But in order for all these systems to talk and communicate with each other, it is really imperative that they have this common language. So next slide, please. So potentially what this common language can be is what we have here on this slide, and that's the ELTSS data set. And we just wanted to take a moment to show this slide because it just provides a more simplified snapshot of the data set. So this data represents a minimum data set which implementers can build upon. It includes areas related to the individual's goals, assess needs, risks, among other things. This data, when standardized, can help improve care coordination, support program analytics, help administrators understand how many individuals are achieving their goals. It could help with quality improvement initiatives and a lot of other areas that we haven't thought of yet. So it certainly is a very exciting data standard, and definitely want you all to hear more about it. And with that, I'll actually hand it back to Angie.
Thank you, Brenda. So ONC invited us to apply for the LEAP grant in Missouri. Oh, do we get to the next slide? Okay, yeah, so ONC provided us the opportunity to apply for the LEAP grant, and that LEAP award is really focused on testing and implementing the ISPR individual support plan or person-centered planning. I'm using the national ELTSS standards that Brenda just shared with you. And so I really think that our team, we pulled together a great team, and they did a great job laying the foundation for the work, learning about how we can capture and aggregate the data, and how we can share the data between our supported employment providers and our case management entities, and really just how that would support then the supported employment use case and value-based care model that kind of Dwayne talked about earlier with the employment services. So on the next slide, I want to share with you who all participated as part of our work group. And you can see there's a variety of vendors here and providers. Of course, we had our team here at State of Missouri. We had EMI advisors. There are our contract helping us with the project management. Our IT actors were FEI systems, and then we had patient-centric solutions. They acted as our health information exchange, our health information network, the hub. We have SetWorks that works with our supported employment providers, and then Station MD, who acted as our primary care physician. Our supported employment providers themselves are they're our local county Senate Bill 40 boards, which was ACT. We have Impact Group, and another one, Learning Opportunities. I'm sorry, these are our supported employment providers, not the targeted case management providers, but ACT, Impact Group, Learning Opportunities, and County Connections. And then our Senate Bill 40 boards, which are typically the counties, were our targeted case management providers. So we had Boone County Family Resources, and we had Franklin County, Adair County. So just kind of a variety throughout the state. They spent a lot of time together working through and developing this use case, and they really got into the weeds of what happens in a person's life on an everyday level and how that interaction can occur between the providers and the people in their lives. So I really appreciated all the work that they did and the preparation that they did for the Connect-A-thon. So I'm going to turn it over to Cecil. Oh, go ahead.
Quick question, Angie, if I could just jump in here for a moment.
Yep.
In terms of this work group, are they all, how were they attracted? How did you bring them together? How long were they working together? Were they all volunteer? Were they all on a contract separately?
Mm-hmm.
Can you say a little bit more about that?
Yeah, that's a good question. We really reached out to the employment providers. So Dwayne talked earlier about we're an employment first state. And so we had employment providers and counties that really rose to the level of achieving additional employment services to the individuals that we serve. And so we had approached those providers and counties that had really hit some high level benchmarks for us. And that was kind of the impetus of starting it off, of seeing, you know, who would be interested in participating. And thankfully, they all were interested in doing it. As part of our LEAP grant, we were able to build in some stipend amounts as well for the work that they would be doing with the work group. And just their time in the meetings, their time on participating in the Connect-A-thon, and then some of that system work that they would have to do to be able to set the system up and get it ready for the Connect-A-thon. Like I said, we had some of the employment providers and the case management providers, actually 2 of each, would have been during the Connect-A-thon observers. They helped us develop the model, but then they just kind of observed during the Connect-A-thon, and then the other 2, the one employment provider and one targeted case management entity, they were the ones that were actually participating and sharing their data. I think it took, we pulled them together in November of 2020. It took the full year for them to get ready to kind of understand what we were talking about when we talk about value-based payment models and we talk about the data interoperability. I can tell you when I first started this, it's a little embarrassing now, but when I first started and everyone was talking about HL7, I had no idea, or FHIR servers, had no idea what they were talking about. I'm a data person, I'm an accountant, so that meant nothing to me. And so I think whenever you talk about some of our case management providers and our employment providers, that was all new to them too. And I think that's one of the biggest hurdles that states have, is you have program people running these services and running these waiver programs, and they're not technical people, they're not IT. And so you really have to be able to bring that, have that bridge to be able to explain what all of this means. And so we spent quite a bit of time with that. And I think we met twice a month, every month for that almost year to get ready for that.
That's great.
Yeah. So I'm going to let Cecil kind of go through the story overview and get us ready, and we're going to share a little bit and do the demo for you, or share the demo with you for our Connectathon. So,
Yeah,
Cecil?
thanks, Angie. And yeah, we're really excited to share the demonstration with recording with folks. But before we get into it, yeah, as Angie mentioned, as part of our pilot work, we worked with all the pilot participants to develop this story, which included personas. So wanted to introduce you to Henry, who is our individual with IDD. We had John, who's our employment consultant, really is the one that would support Henry in being placed in a job in the community. Some of his, greatest joys at work are really helping the folks that he works with get placed into jobs that they, enjoy and find fulfilling. And then we have Stacy, who's our service coordinator with the Targeted Case Management Agency, very detail oriented, effective communicator, and also loves working with her clients. So as we started this process, we wanted to ground the group, in these personas and who we'd be building out the information and technology for. And then in creating the compelling story, we wanted to just give you a preview of the scene. So you'll see this as part of the recording, which we'll show in just a moment. But just to kind of at a high level ground you on what you're about to see, we start with, Henry is meeting with Stacy during an annual ISP review meeting. That's the individual support plan. And so we outline here, the personas that would be involved in each scene, the key steps that happen, and then the system transactions on the bottom. And so, the first scene is, Henry and Stacy meet, and then, many steps kind of happen in between, but then we shift over to scene 2, where Henry is referred to John, his support and employment consultant. He discusses, what his goals are, and then, maybe weeks later, Henry does have a chance to visit his primary care provider, and you'll see kind of what happens through that interaction. And then, potentially weeks or months later, Henry is placed at a job. And then we go into scene 5, which is then, Henry is meeting back with Stacy at a quarterly ISP review meeting, and he's looking at the status of his goals. And then I think at the end here, we show how that data can be used to support the division's design of a value-based care model. So excited to share with you the demonstration, which will be about 15 minutes, and just show a portion of those scenes. And then this slide here just shows, as we went through this process with this diverse stakeholder group, we really wanted to map the different process steps and that workflow of Henry's journey. So this just shows some of the more complexity of the steps that might happen behind the scenes. And then lastly, this is just the high level use case. So we have FEI, which is our online case management system, where the ISP is captured and then shared with patient-centric solutions, which is serving as our health information exchange or health information network. And then you'll see patient-centric solutions is able to share then that data with SetWorks, which is John, the support and employment consultant's IT system, as well as with StationMD, which is the primary care provider's EHR. And so just a moment, I'm just going to switch my screen and go over to the recording. Okay.
Okay, let me share my screen. Thank you, Chrissy. Can everyone see my screen now?
Yeah.
Okay, good. So I'm logging in as Stacy here. And then I'm going to search for Henry, our patient. Then this is a dashboard for Henry. I'll quickly go through the profile feature we have here. We have Henry's first name, last name, gender, date of birth, age, ID, and Henry's address, phone, and then ethnicity, race. Also Henry's language of choice, and then emergency contact of Henry, And also identifiers, we have SSN and Medicare number, insurance number, driver's license, and also the Medicaid number logged here. And then also some program eligibilities. That's all for Henry's profile. And then I'll quickly go into Henry's PCP. And this will be the overview of Henry's plan. We will have the effective date range here, and then I'm Stacy here as I'm logging as Stacy here as the case manager. And then we have Henry's preference here. Henry would like a job that reflects his interest of fishing and gardening. Henry prefers to sleep in and would not like to start his job before 10 a.m. And then we also have the risks that we have logged for Henry. That'll be 3 risks: history of antisocial behavior. We have a mitigation here, which will be home visits and parent training. And then the second risk will be asthma. And then the risk mitigation is meet with primary care provider to discuss inhaler usage and steroids. Then the third risk will be seasonal allergies. And we also have a mitigation here. Next then will be the needs that Henry has. Like first, it will be Henry has a needs to work to earn money to purchase a new TV and additional fishing rods. And then the other needs is he has needs for nutritional services to eat healthier and have more energy. The third one is for transportation services to get to work. And then we have goals for Henry. He wants to be employed. And the second goal is Henry wants to be healthy. And then we have the waiver providers here, the job avenue specialists. And then we have 3 services added for Henry's plan. First one is the career planning. Actually, from the yesterday's testing, we actually changed the units from 1 hour to 15 minutes, as Chrissy and Nancy mentioned. And then also we changed, since the total units are 4 per year, we also did that change here. We also have the second service, which will be supported employment for Henry. And the third will be job development. And the total cost will be here. And then the strengths for Henry, which will be mobility, ability to lift and carry objects, attention to detail. And then the risks are also logged in the risk module. In the intervention section, Henry needs assistance with becoming employed. And the second will be Henry will meet with his primary care physician to discuss how his health could impact his ability to work. And then after that, we have person surveys. In this section, I will ask Henry to answer these questions and log his answer here. I will quickly go through this questions. Please stop me if you guys have any questions about this survey here. Yeah, and then at the end of this plan, there will be signatures from Henry himself and my signature here as case manager, and also the provider's representative signature here, which is John Gomez. that'll be all for the individual support plan for Henry. Nancy, let me know if you're ready to let me push to you.
Yes, we're all set.
Okay, I'll push to you.
Tell me when you're done and I'll go ahead and take the screen. And I
Okay,
can go ahead and do this now.
okay, yeah, it's already done.
Thank you. Okay, so we're representing the HIE, and Jima will have just pushed that ELTSS data plan to our system. So normally we wouldn't be checking at the HIE, we'd just be automatically moving it on to the other places, or other people would be acquiring it from our system. But we're going to take just a minute because we're discussing interoperability, and we want to see that it actually came into the HIE. So before Jima started her demonstration and her transfer, I did a search on Henry, and we can see here that we did not have Henry in our database. I'm going to go ahead and redo that search now. So we're looking for Henry. We're going to go ahead and do a search, and there he is. So she did indeed push the data. We can take a look at it. This is all of his demographic information, all of his IDs, his emergency contact, address, and what have you. And then let's specifically delve down into the care plan. So this is the care plan that the FEI systems just pushed. We can see that the author was Stacy. We can see that his strengths are his ability to, he's got mobility, ability to lift and carry heavy objects, and attention to detail. We see his preferences about his job, some of his particular goals. He wants to be employed and healthy. The particular aspects that this plan addresses, this need to work and earn money. He also needs some nutritional services, and he needs transportation to get to work. We talk about the various activities that were defined by the waiver service plan, as Jima pointed out. For those of us who were on yesterday, we can see that the units now, I guess we don't have all of our units, but this should be minutes. But we also see the cost, the cost per unit and the number of units and the total cost for each one of these services. And then down in the signature area, we see all the people involved in the plan with each of their signatures and the date that they signed. We have our risk managements and risk management plans. Again, I won't go into all of these because we just did that in the FEI presentation. And then the various questions that we had, it's kind of person-centered questions, focusing on their ability to be involved in the plan and their agreement in the plan that was put forth for them. So indeed, they've sent all of the information we were looking for, and it currently exists in the HIE. So while it's critical that we exchange clinical information between clinical providers, it's also important to make this data available to other members of Henry's support team. So in this case, the employment service has an important role in not only supporting Henry in finding a job, but also being part of the overall solution of improving Henry's overall health in a more holistic way. So for our story today, we're going to be pushing the ELTSS care plan to SetWorks, who'll be providing employment services to help Henry find a job. And then later, the primary care provider will be pulling data from the HIE to inform care during their next patient encounter. So let's go ahead and do that. And I'm just going to grab the patient ID as part of this demonstration. So normally this would happen automatically. We're using a utility to kind of control this. And we're indicating that the data we're exchanging is the ELTSS IG. The source of the data is the endpoint for this HIE. And then we're sending it to the endpoint to SetWorks. So we've pre-populated those two source and destinations. We're going to put in the patient ID that we're using. And I think when we're ready, we're going to go ahead and start this transfer. So SetWorks, are you ready?
Yes, Nancy.
Okay, here we go. And you can see we'll be loading up the data resources and then going ahead and sending them off to SetWorks. So he can let it, you can let us know if you receive them. And I think I'll sign off, and SetWorks can then continue the demonstration.
Sounds great. So I wanted to quickly show our scene list here to everybody. So we are currently in scene 2 at this point. I just wanted to kind of make sure everybody is aware of that as you're following this. So my scene is basically around John, John is a employment consultant who specializes in getting individuals with IDD satisfying and rewarding jobs. Okay. So John recently was notified that he has a new individual, Henry, that he needs to try to find a job for. So one of the first things John's going to use, he's going to use Setworks here. And I'm going to go ahead and log in as John and go to my dashboard here and go to individuals. And sure enough, there's Henry's information. So one thing about this is John knows that this information is going to be in the system. He knows that Setworks is connected to the state of Missouri HIN, the HIE, and he knows he doesn't have to do anything. He knows his information's in here. So John's going to log in and he's going to bring up Henry's information and going to go to care plans here and basically just review this LTSS plan and kind of open it here and kind of look at things like goals, needs and observations, some of the things that the other providers talked about that an employment would be doing. So he'll look at this information, kind of see some takeaways that he needs to do, might schedule some meetings, work on some employment plans that he needs to do. But he'll basically review all this information and then kind of come up with a plan. But basically this is what this scene is about, just John having all the information basically ready to go, ready for him to consume. And kind of the conclusion of this scene, John's now going to go to work and work at trying to find Henry a really rewarding job that kind of has these needs in here. And one thing, he's going to look at the strengths and the preferences and risk assessments about allergies and things like that. So that's kind of one huge benefit we get from being connected in a network like this. So I'll go ahead and cancel this. And as we go into the next scene, as John goes to work to find Henry a job, basically now we're going to go to Bruce callback from Station MD, where Henry has to go do a regular visit with a primary care provider.
So let me bring my screen up here. And here I'm bringing up our Station Connect EHR, which is our product from Station MD. We can see that we have Henry Jones in here for scheduled appointment. He's having a pre-appointment physical. So he shows up on our board. We do both acute care and scheduled. So if it's acute care, somebody can call in with an urgent matter and they get put up in dynamically. It really doesn't work much differently once you're on the board, but once he's on the board, you can see here's Henry, here's some information about him. This is all information we knew before we started. I can click on him, and what it does is it brings up his chart essentially. So this is this visit, and as the doctor, I'm going to examine him and create my own note, so I can create a note on what I'm doing. But before I do that, I go over here to other documents and visits. Now, what you can see here is this is where we store information that was provided to us about Henry prior to this visit. And we currently live in the world of IDD, where we get a lot of things via fax. We have stacks of documents, and this is one of the things we're complaining about with something that may not look great for doctors to go through a stack of notes that look like this. So I'm really excited about this Missouri LEAP stuff and getting this information dynamically. This was the last information we got. It was from 9/9. Normally when the patient's created, we'll fetch this data automatically, but I'm going to manually refresh it here. It went through, did the entire update from the PCS system from Patient Share, and I can click on it and I can see all the information that's up to date. I'm not going to go through all the items, but be assured that the same as with the other systems just showed you, we had no interaction with them. We had no discussions with them. It didn't waste any person's time to collect this information. The doctor can look at this, look at the goals and strengths here. Henry wants to be employed. Henry wants to be healthy, and he's got strengths and mobility, ability to lift objects, and the attention to detail. One of the things as a physician, I'm not actually a physician, Dr. Trevetti is, but if I was a physician, I can look down here at the risks. And this is something I'm very interested in that I normally might not collect from patients in today's world, or it might be inside that stack of PDFs. So he has a history of antisocial behavior. That's fine. The seasonal allergies is something that I want to look into. I want to meet with. He's going to meet with me and discuss use of the inhaler. So maybe inhaler and steroids would be prescribed. I'm going to examine him using our digital stethoscope, using our cameras, using our mobile app, whatever he has at his facility to diagnose him and treat him. So when I ask him about the asthma, do you have, how much does the asthma affect you? Can you lift things with the asthma? Can you be outside? All the information, obviously, we got if we need to talk to another physician about it or need to talk to somebody else to coordinate services, we can do that. One of the really nice things also we're seeing is if there's any discrepancy between the data that we know about Henry and the data that was just provided from the patient share, we can see the differences here and maybe update the data that we have to make sure all the treatment's correct. So what we're finding is that with the additional information, we can make better clinical decisions. So we have the strengths, we have his skills, we have his ability, his talents, and we can make more informed decisions. So we're going to make a recommendation based on about his meal plan, his sleep schedule, and we're going to push that back out to Stacy. Our system can automatically at this time notify people via an email, a secure email, via a fax, and we also can do follow-ups with nurses. But I can really see where the ELTSS will allow us to publish this back out later with the patient note. So I guess now we're going back to Nancy from Patient-Centered Solutions.
Okay, this is Sheetha. I'll pause the recording here so folks got to see the majority of it, and then I'll kick it back to Angie, who will be able to kind of just share a little bit more of the summary of highlights and lessons learned. So Angie, I'll give it back to you.
Thank you, Sheetal. Appreciate that. So yeah, so you kind of saw that movement from the case management provider through the employment provider, which they're all part of the planning team already in our HCBS system. But then they're able to see that electronic transfer of the data along with then to our primary care provider that can help build that care coordination around them. So in terms of highlights, we did, again, kind of engage with that diverse set of stakeholders. You saw the clinical, the non-clinical, the home and community-based. So we were really excited about being able to do that data exchange with them. Oftentimes, our population that we serve in the IDD population, developmental disabilities within our home and community-based services, they oftentimes have a hard time recalling issues, information, or even communicating with their providers. That can be challenging for them. So when we talk about engaging our providers, we're just really excited to be able to see how that data was shared electronically, and that primary care physician can pull up information immediately. That supported employment provider can pull up that information immediately, like, okay, if there's allergies, we want to try to keep them from working outside, and whenever allergies are flared up with seasonal allergies. So we were really excited about seeing that real-time, clear communication across the providers. On the next slide, a few more highlights. Just having that cross-facility exchange. They used multiple FHIR API vendors, multiple provider types. Some of them pushed the data, some of them pulled the data. We had the demonstration of the clinical value to each collaborator. I go back to Station MD showing that handwritten note that's a lot of times hard for them to read. So when you have that actual plan in the electronic format, that makes it so much easier for them to process and to get the appropriate care coordination wrapped around the individual. The new fire implementers that were in our group really found it easy to understand and implement, and just that appreciation of that high value add to their systems, to those target users. So we were excited about that. On the next slide, we do have some of that immediate feedback that we received was just a lot of eagerness to see this put into production, both on the clinical and the non-clinical service providers. So the use case targeted individuals with our IDDs, they often, again, like I said, have that challenge of recalling information. So here we have some of our providers are like ready to, let's do this now. It's transformational for our clients, for providers, for budgets, and the excitement to see it all come together. They all have different kind of care settings that they can see the improved outcomes on all sides, clinical and non-clinical. So some of the benefits that they talked about was efficiency, improving the quality of service, time saving, ease of use, and just access to data when we needed that informed care. On the next slide, we do talk about lessons learned, and we have a report that we've written, and that's posted on our website as well. So we are halfway through our grant period, and we've already learned a lot of valuable lessons just through that Connect-a-thon experience. Engaging a diverse set of stakeholders was really key to the pilot success, but we would like to directly engage the individual and his or her family in the work group process in the future. The individual and his or her family could receive and share the data as well. And then also in order for the use case to move into production, we just need to have deeper technical considerations related to patient matching, security, care plan updates, electronically capturing units of service. That was one, you may have heard that whenever we were testing, we realized the units of service was a little off, so we fixed that. And so we really need to look at that in the context of our waiver services. So more discussion would be needed around that. On the next slide, we have a few more lessons learned. Education, I talked to you about education earlier. We need to really help bring people along to understand what ELTSS data really is, who can use it, and what it's used for. There's also a lack of incentives and market demand. So with the federal and state, we really don't have language that instructs IT systems to adopt this standard. And so what we found is that this would be an extra cost because it's kind of falling outside of the scope, even though that's kind of where the market is moving today. So we did notice that there was a little bit of a struggle there. And then just again, the importance of the internal staff capacity and just understanding of what all of this is, the IT infrastructure, how it really works, and then what it really means to us and to the individuals that we serve and to the system as a whole. So on the next slide, we have moving forward some of the considerations that we want to do. There's a lot of eagerness in putting this into production. And so moving forward, we want to continue to work to secure funding and finalize that movement of the use case into production. We are, in this last year of our grant, developing an implementation-focused VBP, value-based payment roadmap. We want to continue to identify opportunities to align the data infrastructure and interoperability efforts with our partner agencies and stakeholders. So our Department of Health and Senior Services that operates 4 other home and community-based waivers, also with our sister agency, Department of Social Services, that's our single state Medicaid agency. So again, we really see those benefits across all 3 agencies of the quality of service, ease of use, and time saving, but we do have some things we want to lay out as we move forward. So that kind of wraps up like our demonstration. I don't know if anyone has additional questions or thoughts.
I'll just add, in the way that technology goes, when we did that initial recording, of course, someone's microphone was on and they were blowing their nose. So every time we get to show that recording, we get to hear that same person clear their sinuses. And so we apologize for having captured that in the one-time recording of the live event.
And then our giggling every time we present it with the recording. Dwayne and I can't help but to giggle a little bit because we did not hear it when we recorded it, when we were going through it. It was like several times later, and then we're like, oh, did you hear that?
we can have the outtakes award contest for Connect-a-thon recordings and see who's
Oh
got
my
the
goodness.
most
right?
entertaining ones. That was great. That was great. Made it human.
So I had a question
Yep.
for Angie, just specific to what you're calling your VBP strategies. And earlier in the presentation, you mentioned that you, I guess as part of the measures that you had to capture, you had to also select VBP measures. And I wanted to see if you could just talk more about that process or how you came or coalesced around those.
So I'm sorry, how we collect the VBP measures?
No, how you actually selected them, like how you got agreed upon them for this whole like grant and what you're measuring and collecting.
Mhm. So our grant is really focused on that interoperability. So, and that the LTSS standards. We had started off, we have a lot of use cases. We have where we wanted to look at behavior support, kind of diversion from emergency rooms and urgent care through behavior crisis. We also had a medical one, and then another one was this our employment. We're still trying to collect data on all of those measures. The employment was one, we chose it because we felt like it was further along the process and it was more of a manageable use case for us to work through with the LEAP grant. We still have, as we're working with that interoperability piece and sharing that data, as we move towards value-based purchasing, we're going to focus now in this next year on, okay, as we have that data interoperability, what are those particular measures that we're going to be looking at within the data sets and the data standards that we have. So I'm not sure if that kind of answers your question, or Dwayne can more add.
And I'll just add in, Rita, also kind of on a parallel track to this is Missouri had been awarded for about 3 or 4 consecutive years technical assistance through the U.S. Department of Labor Office of Disability Employment Policy. So we've had access to various national subject matter experts around some of the desired employment outcome metrics. And then also we've had the opportunity to talk to a couple of states that have implemented a level of VBP in some of their managed care worlds. And so, what we are trying to do is align some of those potential metrics around the technical assistance that we've gotten from those subject matter experts, supported through the State Employment Leadership Network that we've gotten through the U.S. Department of Labor Office of Disability Employment Policy, and then just also from learned experiences of other states and other systems on what they have considered as some of their value metrics. So, so we do have some that are kind of drafted, but I think what we continue to want to do is get to a point where we're getting data and collecting data, and we can see where we may need to modify some of those metrics at.
That's great. Other responses, questions? We're coming up toward the close here, but I want to make sure that any questions or thoughts, responses. So one that I think, Angie, you addressed in the chat was about consent.
Mm-hmm.
And I know it's on your roadmap. Imagine in this situation, you'd be looking for both a HIPAA and 42 CFR in terms of consents.
Mm-hmm.
And are you, what kind of thinking are you have around that at this point?
Okay, so that's early on in our thought process. Okay. I do know that right now the employment providers, like the providers within our system, they already have the ability to see that information and share that information because they're all part of the planning team. So our employment provider and our targeted case management provider are all part of that planning team, so they can already see that information. So really where we need to consider the additional components is when we start to reach out to other providers outside of our DD waiver services. And so again, this is something that we'll need to work through as we work with our legal counsel and the other agencies in that roadmap model. But we really again, in this LEAP grant process, we did not necessarily bring all of that in
Sure.
or test that component.
One of the, just to dig on that a little further, because it's just been kind of top of mind for us in terms of these areas, and certainly long-term supports and labor have not been in the center of where we've been looking, which is more job welfare and education and behavioral health, but there's a connection to behavioral health as well, which is real interesting.
Yeah, and I know whenever we started this early on, we talked about that data sharing component. It does get into a little more complicated areas whenever we start talking about services on our behavioral health and substance use disorders, because there is a different level of HIPAA compliance and PHI on that outside of the normal medical data sharing. So we do know that's an area that we do have to look into more to make sure that we're accounting for those additional criteria. Because I don't think, if I remember correctly, I don't think that is covered even under the normal like HIPAA, the consent pieces. So, and we do have waiver participants that are receiving services, from us as well as the behavioral health side. So,
Chris
really something that helps flush out.
Chris Albertron, who was on the call earlier, is at the Network for Public Health Law, and she's been leading a lot and contributing a lot to the consent and the legal privacy part of what we're talking about here. I also imagine that in this case, some people probably have guardians who are consenting for them as well. So yet another level of complexity in terms of managing and handling that. That's interesting. Or it's more interesting than even more interesting.
Right, right. Again, our onion layer.
Yeah, it's a big onion there. I would encourage and invite and cajole as you think about that more. Think about how we can sort of add that piece of the onion back to the consent work that we're doing and add into it, because the questions you're answering through technology and all of the other great stuff, the collaboration that you've done, would be, of course, obviously relevant to many other people across the country, both in the LPSS program and the INC programs and the SIMS program, that all these major programs here are all having to deal with that. So we welcome and encourage your more learning about that as well.
Thank you. We do appreciate that. We really do.
Yeah. Well, with that, we are in overtime. Sometimes we go into double overtime, but we're just in overtime right now. So I just want to thank you so much for the great work. It's exciting to see it and for you to share it with us. We'll post this on our site and make it available to folks as we go forward, and invite you to participate in whatever ways that you find useful and helpful. Pass the word around. And with that, I think we're off, as I said earlier, for 2 weeks. We won't have anything the rest of December, and then look for announcements in the beginning of 2022 for where we'll be headed next. Should be some interesting times as we move into the new year. So thanks everyone. Have a great break, hopefully, a great time off and family, and be well.
Thank you very much for having us again.
Thank you.
Thank you. Happy holidays.